right, Mr. Bromberg, it's a pleasure to have you on the show.
Good to be here with you.
This is where all the magic happens, huh?
Yeah, it's a magical place.
You said you have another office up in where, Wellesley?
Wellesley, yeah.
Okay, so right now we're in the Newton office. Thank you very much for joining me. I think you're definitely whether you realize it or not, a really big name in the industry. You've made a huge impact in Massachusetts healthcare, and your whole career has been in Massachusetts. Is that right?
Yep.
Okay.
Yep.
So I want to get into a lot of the stuff that you've done. You know, we've been talking about it on LinkedIn, which I know you're a really big fan of LinkedIn, right? Yeah, most people
as much as a dinosaur can be.
I feel like, yeah, not a lot of people really are big onto LinkedIn. But nonetheless, I think that mental health care, it's interesting because episode 1, we had somebody on who is a specialist in addiction medicine, also did PCP stuff. And then we have somebody who's doing, in the second episode, somebody who really deals with the most vulnerable communities in the community healthcare environment. And now we have you on, who's definitely one of the forefront folks who have implemented mental health in the Massachusetts landscape. So, I mean, I guess just to start, for how you got started in this, and it sounds like we talked a little bit before we got started here that a lot of it was mentoring. So, you know, whereas you're now in a position where you've had how long of a career now in this field?
35 plus years.
35 plus years. And I imagine you've mentored people throughout this time too.
Yep.
So a lot of people gravitate towards this field because I think, honestly, there's a huge need, and it's a lot of people who have a lot of passion to help other folks out. I mean, I personally have never, and you've done a lot of work in pediatrics, but I have never met a child or an adult in my life that didn't have at least one terrible event in their childhood that they didn't deserve, that wasn't their creation, that something was either by happenstance or by somebody else intentionally inflicting something. Nobody's really seems to have just a childhood that's like, you know, you want to see on TV, right?
Well, that's TV. It's not the real world. I mean, it's, you know, it's a fact of life that it's not going to be easy all the time, I guess.
Yeah. So, and I'm sure it varies in intensity, but I guess I wanted to start with talking about, let's talk about mental health as a whole here. So I'm going to put to you a thought process that I've kind of gone through, and I'd like to know if you agree with it or not.
Yeah.
So, like, I look at westernized medicine, what we know as like healthcare, typical healthcare, is being roughly about 2,000 years old. And there have been so many advances over time with it to get it to where it is today. You know, even just in the early 1900s when vaccines first came out, and that was like antibiotics, huge game changer. But if you even go to like the 1500s, we were still like cutting off boils and thinking that was an appropriate way to treat wounds. If you even go back, 50 or 75 years, we were still doing lobotomies. And that's after almost 2,000 years of a process of trying to learn the practice of medicine. Now, mental health, I feel like, is far younger. I feel like mental health, depending on when I've looked at it, is roughly about 100 to 200 years old as far as I think of really kind of the progress, the push into trying to really understand how the mind works. And please correct me if I'm wrong on any of this, but I look at it like mental health is in its infancy, and you have so many folks like yourself doing amazing work, but you know, where do you see where we are at right now? Like, I look into just the expansion of autism and our understanding of autism in the last few decades.
It's a great example.
And I feel like if you go into autism, especially when you see the Venn diagrams of overlap of like ADHD and OCD and things like that, I feel like we're going to have dozens of other diagnoses down, you know, a generation from now, really better understanding some of these conditions. So where do you think we are at with this?
Well, it's interesting. That historical perspective is interesting because Western medicine at some point definitely split the mind and body. I mean, these older systems of medicine, these ancient, you know, like Ayurvedic medicine or Eastern, you know, types of medicine,
yeah,
they were focused on the connection of the mind and body.
Okay.
You know, and actually, when I started doing this work, when I would explain it to people, I'd say, well, we're reattaching the mind and the body.
Yeah.
You know, we're bringing them back together.
Yep.
And so that's, I think, what's happened in Western medicine, probably, you know, maybe since the really the 50s, 60s when, some of that stuff
Right.
started, the foundation of it started to build.
Yeah.
But if you look at these ancient systems, these old systems of medicine that really kept the mind and the body together, and that was purposeful. And
So it's like mental, what we call mental health care. Is that more advanced in more Eastern medicine techniques? And
I think people might say, mental health is health.
I totally agree.
Right? It's a whole person.
Yep.
It's a mind and a body together. So why treat the body there and the mind over here?
Well, yeah, not only that, but we also know that one affects the other.
Right.
We know people get, you can get hives by anxiety. And,
right.
And there's sometimes very obvious crossovers
Yep.
with the two. And it seems often silly to me that, whether there's been a stigma in the past for it, and which is tremendously improved. Every decade, I think it gets tremendously better.
Yeah.
I mean, folks that are seeking therapy has just skyrocketed. If you look, I'm sure you know this stuff better than I do, generation by generation, decade by decade. So that's at least going in a really good direction. I just have, I guess, I have a lot of hope that, like, the way I look at it is, I get concerned with, even, let's say, with my daughters. Both of them are on different medications, and how accurate, like, and I know everyone's trying their best. It's not like I'm looking at this from a, thinking anyone's really being nefarious. I think we have great clinicians, we have great counselors, we have great psychiatric help as well. And everyone's doing their best. I wonder how sure we are about some of these diagnoses. Like, so,
Right.
I can't remember the name of it. You're going to know this one. I think it was in the 70s or 80s. There was this, was it Harvard put folks into some kind of mental health facility with saying that they had some kind of diagnosis, and the folks there weren't aware that they didn't actually have those diagnoses. Do you know this? I can look it up in a minute. But there was, I guess, this is in the 70s, and it's been many decades since then. But my concern is, like, how we clearly know if somebody has the flu or strep, and trying to understand people's mental health conditions, especially when there's crossover and someone seems to be suffering from multiple diagnoses. How complex is that to diagnose, and how often do we get it wrong?
In many ways, it's diagnosis, because there is so much overlap. It's an art, not a science. I mean,
Right.
It's a science in some way, but there is an art to it.
Yeah.
And you might have two individuals that are presenting sort of same picture, but let's say they live in completely different contexts.
Yeah.
Their lives are really different, but what they're displaying outwardly may be the same. Could be a very different thing. Could it be the same thing?
Right.
You asked her a little bit ago, like, we're in this infancy. Where are we going with this? And,
Right.
if you think of, our ability to look inside the brain, like brain imaging, and our understanding of genetics, genetics certainly, I think, is a growing area that people are very interested in terms
Sure.
of understanding the interaction of the mind and the body. I remember early on in my career, there was a guy here in Boston, a physician named Herb Benson, who was really associated with this idea of the relaxation response, really, one of the modern sort of founding fathers of this mind-body medicine. And I remember attending a lecture that he gave where he was showing some brain imaging of people, invoking that relaxation response. And it was incredible. I mean, you could see it,
Really?
on these brain imaging things, you could see people's, the imaging changing as they became more relaxed. And that was pretty compelling. I mean, to have that look inside and say, wow, this, it's not a real mystery. There's something going on here. We may not know exactly what it is.
Right.
But look, you can see it.
Right. Interesting. Yeah, I've seen some. I remember I saw some study. I believe it was a study. I hope I'm not talking out of some hypothetical here, but I could have sworn I saw something talking about people who were like atheists versus folks with faith, and regardless of what the faith was, at certain parts when they would pray would have a certain reaction in the brain, and that atheists didn't have the same reaction, even if they were trying to meditate and do anything similar to it. So, I mean, I think it just, there is a lot that we don't know of how things work. And of course, a lot of it is through conversating and folks can also,
Yeah.
a lot of it depends on how open the individual is that you're talking with. And I was pleasantly surprised today to learn that you still provide psychotherapy services.
Yep.
So that's which is really great, because I think a lot of folks who um, do some of the work that you've ended up doing, like scaling things up, being an architect over with your work with Boston Children's through the PPOC, don't keep their hand in it. And the fact that you still do is great. I mean, I think it's I imagine it's something that really just kind of keeps you in a place where you can understand and better provide your other services, like consulting services and things like that.
Yeah, I always have kept a hand in it. As I had a couple of big jobs that took me further and further away from direct care, but I always kept a hand in it because, the reason I became a psychologist was, to help people. And my work took me, further and further away from that, but I always stayed connected to it. And, that helping people part of it was important.
Right. Which it's funny that you word it like that, because you've probably helped way more people in the work that you've done with the PPOC indirectly than you did direct. Well, I don't know. I don't know if you can really compare the two, but you know what I mean? From one session to one session where, you might be able to treat 30 people in a week directly, and it's much more impactful, and you see the results immediately, and an ongoing experience must be fascinating. I can't even imagine what that's like. And then you have what you've done on the PPOC. I guess we can transition into that, what that was like from your perspective. Because I imagine you had other folks that you worked with. I mean, I think I know a couple of them, but, explain to me, were you brought into the PPOC for this purpose, to integrate behavioral health? I know you were playing around with like telehealth prior to COVID coming in, which really helped you launch that throughout the state. And a lot of practices, even non-PD practices and non-mental health practices, were copycats. They saw what you were doing and used you as a model. Can you explain, put us into what that environment was like?
At the beginning of the program? Yeah. So I, long story how I got to that place, but they were in 2013, the PPOC had this idea of launching this integrated behavioral health program. They brought me on to, direct that program. And we built it from the ground up. And there were, three major components to that. One was there was a big clinical education component where we wanted to, equip the medical clinicians in these pediatric practices with more information about how to understand and care for patients that had behavioral health concerns. So big clinical education piece. We probably were doing about 60 hours of, CME accredited training for physicians, nurses, mental health people as well, annually. Second was that, integrating clinicians into the, pediatric office and helping those teams learn to work in this new sort of integrated way. And then we developed some ways of helping those care teams get more direct access to expert consultation, clinical consultation, to help them when they had questions or were stuck with something. And so those were sort of the three kind of, pillars of the foundation that we built. Back in 2013, the PPOC, there were about, approximately 80 practices and operated in about 100 and something locations. We recruited 15 practices to start with to participate in that first group. So they enrolled in our learning community and we started teaching them. And over time, we helped them operationalize this, hire people, begin to integrate them and work in this new way, and opened up these avenues for expert consultation. So that's where it started.
Yeah. And that's awesome how you got it started too, because I think what a lot of people probably don't know is that doctors and nurse practitioners that focus on the medical side of things get very, very little mental health education through the process. I mean, I remember around those days, because I was following that project when you were there, well before you and I met. And I remember researching at the time, and they said some of the programs had like 4 to 8 hours throughout your entire education piece that was focused on mental health. So basically, they weren't really much more equipped than I was for being able to foresee, there, if somebody had it, to even ask questions, let's say in the PCP office about like, if that lead to things, whether it's social determinants of health, but also like, hey, if grandma passed away over the weekend, that this is, there might be a situation where this child might need grief counseling, or someone or a friend of theirs passed away, maybe they were there and there's survival guilt, or, they have these checkbox systems now, and I think things are still going in a good direction, but you have a lot of them where it's, what 13-year-old is going to check off like, oh yes, I have an eating disorder. They're not typically going to. So how do you anticipate that? And, I feel like folks like yourself can at least educate the medical side so that they can be better at trying to see through like the matrix and pick up on a situation where maybe they need to have a consult with a therapist, right?
Yeah, what you're saying is making me think that I think integrated care probably has a little bit of a longer history in adult medicine. And I think that some of that is largely cost driven.
What do you mean?
That the issues that adult people bring, how do I explain this? They impact, I guess, the mental health side of it can impact the physical health. Let's say, whether it's heart disease or, I'm trying to think of another, diabetes, sort of these adult medical concerns.
I see.
Or even if it's just anxiety, I mean, they're gonna, they cost more to treat. They have sort of collateral costs in terms of, sort of missed time from work or the way it interferes with parenting, I guess.
Right.
But in some ways, so I think integrated care maybe got started, more in, was adopted quicker in adult medicine, but pediatrics is really, an ideal place to integrate that.
That's where exactly.
Because, families, they find a pediatrician, and if you have 2 or 3 kids, you could have this relationship with a pediatrician. So maybe 20 years from infancy, right?
Yep.
And if you're attending to these behavioral health concerns from the very beginning,
right,
understanding them, detecting them, helping families with them very early on, it's going to be easier to treat, less expensive. You're going to change the trajectory of that.
Yeah,
and it almost can look like prevention in a way, or wellness, which is really what primary care is kind of all about. Starting with kids and families when they're really young, building a culture in a pediatric practice where we say, your emotional health is as important as your physical health. And, we're going to take care of both parts of you. Mental health is health.
Right.
We're going to care for you as a whole person.
Right.
And getting started with that, enculturating families to think that way from the very beginning. And then it's just something normal,
right.
Because parents tend to turn, if their kids are struggling in one way or another, they turn to their pediatrician.
Right.
Right. And so it's a great starting point,
Yeah. But I mean, I can't, do you know any people in their, most of my friends will be in their 30s or 40s, and they all have these stories of like, man, I wish I had therapy back when I was 8 and stuff like that. Like they wish they were given these tools or could better understand or even know that they even had an issue to deal with decades earlier.
Yeah.
And and we all know the earlier you catch anything, anything in healthcare, the earlier you catch it, the better the outcome. So we want to catch these things when people are children, which is another reason why I think really the funding needs to be pushed in that direction. I know you've been a champion of stuff. So when you integrated this with the practices in Massachusetts, which by the time you get, let's fast forward to like this 2019, 2020, around this time, now there are over probably, I think there were around 100 practices at that point, and the PPOC are close to it, like in the upper 90s.
Mid 80s, I think.
They were in the mid 80s.
But many of them had multiple locations, so it was over 100 locations.
Okay. That might be what I'm thinking of. So when it came to doing this, did you find a lot of resistance with any of the practices? Did they all know that this is something that's important to adopt?
It's a great question. I think many of them knew that it was important to adopt. I don't know, I guess pushback. There was some skepticism. I don't know about pushback, but You know, you'd often hear, well, listen, I'm a pediatrician. Why are you trying to make me a mini psychiatrist? You know?
Right. Right.
But no, we're not trying to make you a mini psychiatrist. We're trying to make you a better pediatrician,
Right.
you know? And you don't have to do this. You have to be involved in the front end.
Right.
And we're going to help you do a little bit more as a pediatrician to start with. But then if you run out of runway there, you got somebody right next to you that you can, you know, pass off to that can take it from there.
Yep.
You know?
And I think,
and an important part of that was screening.
Okay.
When we started the program in 2013, I don't know exactly, but maybe it was about half of the kids in the network were getting an annual screening using some kind of standardized validated tool.
Yep.
The rest, you know, hit or miss, whether they were getting a screening. Sometimes a pediatrician will say, oh, I've developed my own set of questions, you know, not a standardized sort of tool.
Right.
Or they would say, well, this kid doesn't need it. I'll only screen the ones I think need it. You know? By the time I left the program at the end of 2023, approximately 95% of the kids that were cared for in the network were getting an annual screening for mental health concerns. And almost 90% of the kids 13 and older were getting a screening for substance use. Okay. Which was, you know, enormous change in the rate of screening. And that's really where it starts. I mean, detecting the problem. And that was one of the things. So screening, using these validated tools, and then teaching the medical clinicians how to ask better questions that would elicit that, or you just be able to respond when the parent said, hey, listen, we're having this concern. Often you'd hear from a pediatrician, oh my gosh, you know, I feel so under-equipped to sort of manage this. I don't know what to do. It's going to blow up my schedule. It's going to take 45 minutes in this 15-minute slot.
Right.
The kid's crying now. The parents are upset. What do I do?
That's such a tough position to be in, because it's like, you know, you don't want to just hand them off to, okay, well, yeah, I know here are some folks in the area, which is generally how a lot of the referral process goes. But if you have especially if there's a crisis situation going on, I mean, that's something that you have to deal with immediately too, right?
Right.
I mean, I imagine that must at times come up in the PD office, or what, I mean, most people who I know, and this will probably get a laugh out of you, most people who I know that work in PD say the biggest problem with PD is the parents, like dealing with, like having them understand, like, I can't even imagine in the age that we're in, especially now with gender dysphoria, for instance, the amount of folks that are very resistant to follow the processes of like supporting their child and trying to kind of like strong arm the process. I mean, this stuff gets very complicated. And not just with that diagnosis, but it's an easy one for me to punch in there, because it's a very divisive one to bring up. And when you're dealing with parents who maybe don't want or are rejecting this, or maybe they think that maybe there's still folks that have that old school mindset that mental health and counseling is a crutch. You should be stronger. You don't need somebody to do this, and that type of stuff, where I didn't need it when I'm growing up and my son's not going to need it now. That type of mentality, I'm sure that still maybe it's not a majority of the patients, but it still must occur here and there.
Yeah. And what that's making me think about is this idea that, you know, when you put mental health, behavioral health into, you know, a medical office environment, and say, listen, we're caring for a whole person here, mind and body, it normalizes it, it destigmatizes it. It's not like I'm not in the mental health clinic. I'm just going to my local doctor. I'm going to my doctor's office, you know, and they're caring for me as a whole person. So I think it has a way of, you know, debunking, or, you know, reducing some of that fear or stigma that people attach to these things. By putting it in an environment where I'm just going to the doctor.
Where it just makes it kind of commonplace and less awkward, or something like that.
Yeah, and that was an important part of what we tried to help practices do, was create a message to families that, you know, we're here to care for your whole child. You know, their emotional, mental health is just as important as their physical health. It's normal. We expect that. We want to deal with that. We want to help you with that. That's such a relief to parents. Oh, it's normal, you know.
Right. Well, yeah, and it's just speaking from the parent perspective, and I'm sure there's some parents watching too. If you guys have any comments, throw them in here. I'll be checking over here for that as well. Or really, anybody can ask questions during this live. But I think I don't know. I think as a parent, I just remember with my kids as they're growing up, there would be moments where I'm like, oh my God, why is my kid the worst kid here? And I think it's just because you're the one who's focusing on your child. You're not focusing, you're not looking at Billy and Johnny over there. I'm looking at Adriana, or I'm looking at Sophia. And it's just, oh my God, this is so embarrassing and stuff like that. And you always kind of get this tunnel vision look about like, oh, why does my kid have all these issues? Where it's like, no, all kids do.
Yeah.
Like they're all complex, they're all different. Like when they were babies, you either had a biter or you had a kicker. Or you had the one that couldn't sleep through the night, or they slept through the night, but they had this other issue. They had croup, they had whatever. Like everybody deals with the parenting pains. It's just different, but nobody gets through that easily. So,
once, and introducing, routine mental health screening helps convey that message. Like, if every year when you bring your kids in for their annual well visit and you get a series of questionnaires that ask about these sorts of things, why are they asking me about this in the medical doctor's office?
right.
Well, it's connected, and it helps normalize all of that,
Yeah.
and sends that message like we're concerned about your whole child.
Yeah, and I think like we were talking about this beforehand too, how important it is for like teenagers to get those screenings too of what they can get it sent as a text message. They can fill out those surveys, or they can try to hopefully independently fill out the surveys. A lot of people who aren't familiar with abuse in the home, often the person who's going to be the abuser might be sitting right next to them in the pediatrician's office to keep an eye on what's going on. So I think having those screenings, especially in like the post-Columbine world, and I know that's like really dating. God, that's what, 30 years, coming up with 30 years?
Is it that long?
I think so.
Wow.
I think it was like 96.
It's probably true.
And I am one of the reasons why I really focus a lot on mental health stuff is because I feel like our progress since then has been abysmal overall. I think you've done amazing work and stuff like that, but I just think from the government response to things, for funding processes and things like that, I think that there should have been a lot stronger of a response. I still think that. I'm very glad that we finally have telehealth in Massachusetts. I mean, COVID, as bad as it was, I was so thankful because we've had this tech since the early 2000s, and you have people who are desperate, or even if you still have that stigma, let's say you don't want your wife to know that you have these issues, but you can now just open up a laptop, or people who have agoraphobia, or people who are coming back from service in the military. I mean, the amount of uses for this and need for it to be telehealth, or even if it is just out of convenience, like this is the work that needs to be done.
We were so lucky in March of 2020 because we had started this work to integrate a telehealth platform into our EHR. Probably a year before that, and behavioral health was chosen as sort of the first test case.
Yeah.
And so in the fall of 2019, we engaged a bunch of practices. I think it was a handful, like 7 or 8 clinicians, started piloting what we had built as far as doing telehealth visits. It was something nobody had done before.
Yeah.
We had to, sort of teach people to work in this way, from scratch. But we had about 4 months of experience. We had our platform built and tested. We were using it. And then whatever it was, March 12th or 13th of 2020, when the whole world sort of shut down, we had this, it was about plan was over about a year and a half to roll this out, to the rest of the clinicians in the network, medical and behavioral.
Yeah.
On March 12th or 13th, the message came through, everybody else right away,
Right.
And we were prepared. We had the platform built. We had some experience with it. Not that it was easy, but the first couple months were a lot smoother.
Yeah.
We weren't an organization that had not thought about this before. I know
Right.
a lot of organizations were scrambling. What do we do now?
Yeah.
And the mental health visits, the behavioral health visits, the level, bounced back really quickly compared to medical visits,
Right.
because we had that ability. Medical visits eventually bounced back. There was a little bit of a lag, but, as an organization, we were so prepared. We were lucky that we went into that with so much preparation.
And how did you get recruited into this position? Now, was there someone that you'd worked with in the past, or were there a few of you who were really kind of orchestrating this? Because I know that you're kind of like the figurehead at the top of this.
So I Well, I was part of a team. I mean, I had a leadership position in the program, but it certainly isn't something I couldn't have done without a large team of people, and was very fortunate to be working, at an organization like Children's Hospital that had a lot of resources to be able to, direct toward this in a variety of different ways, and not just clinical resources. I mean, we had folks on our government relations team working on this in various ways, folks in the contracting department working on this in various ways. So, and we used to say this is not just a clinical matter, it's an operational matter too. You can't just drop a clinician in a practice and think it's going to work. I mean, it's an operational matter, and the clinicians are part of it, but, and a really important part of it was the practice administrators too.
Right.
I mean, they make things happen. All that thing, everything happens, through a practice administrator, right? And they became a very important part of the work we were doing.
And that operational, they definitely do not get the respect, not the appreciation they deserve, without question.
And listen, I worked with some phenomenal physicians who loved doing this, took leadership roles.
Yeah.
But the practice managers made this happen in so many ways. They're responsible for making sure that, the office runs smoothly day to day. And when you're doing something new, you're transforming the way a whole clinical team is practicing. You can't do that without the operational people, and that's the people from the front desk to the billing department. Integration, it touches almost everybody in the office, from the people that greet the patient when they walk in the door to the person that sends out the bill on the back end. It touches so many people in between. So we really approached it in this ecosystem kind of way. It's not just a clinical matter, it's a whole transformation of the way your clinical team operates and practices.
I mean, that sounds terrifying. I think the thing I like most about practice managers, and I imagine I'm sure you work with Carol O'Neill, right, over at Mansfield. I mean, that's definitely one of the big leaders, I think, one of the probably shining pediatric practices in the state.
They were one of the first teams to do this.
Were they? Yeah. I mean, they're very well equipped. They have multiple locations. They have amazing services over there. I think they do a fine job. And Carol's just like a staple. I'm not sure if she's still. Yeah, I think she is still there with them.
And not only was Carol behind it, but they had a physician leader too that was 100% behind it. I mean, really, the two of them together really helped.
And the thing too about people like Carol, or God, what's another one? Kim Brewer, I think you work with
Kim Brewer
out west.
Kathy Sullivan down Bridgewater.
Yeah. They were. I think, because Kim, I don't know if you know, but Kim just traded on. She left our industry.
Yeah, I knew that.
If you're watching, Kim, I'm still mad at you for that. But I think the thing that I love most about practice managers is that they are like pit bulls, man. Like they're very much straight shooters. You can't really get something by them. Like it's kind of like you can't bullshit a bullshitter type of thing. Like they're the gatekeepers. They're always extremely strong. And I don't know, like those are the folks that I typically work best with, because there's no fluff in it. There's no cowardice. They're always, willing to go, because they always are asked to do well beyond what their job is. So they typically aren't uncomfortable when they're asked to do more. Like they might complain about it, but at the end of the day, like they will always push that envelope for the practice because they're passionate about it. A lot of people don't get into pediatrics for the money. I mean, it's not like they're all driving these high-end cars. But
you don't choose the lowest paying specialty in medicine if you don't have a heart,
Right.
And that was really cool. I mean, pediatricians, people that work in pediatric offices, they are salt of the earth people. I mean, they're there for the mission, Yeah,
no question.
Yeah.
No question. That's good. So, which I think is a good way for us to segue over to one of the things I want to talk about is about those folks who are coming into mental health that are not good actors in the group. So one of the things I like to do on this show is to call them out. And there's a few in particular, and I know I have Cerebral and BetterHelp. I'm not sure if you've heard of these folks. And then I think too, I'm not really completely sure about Talkspace. That's another potential one, but they all have like this VC backing. And my concern, and again, when I bring these things up, there's no need for you to even respond to it if you don't feel comfortable with it. But you have these. And not that VC is the end of the world. There's been some good stuff that's come out of folks being able to get funding, but there's been a lot of allegations. The first two that I mentioned, they've been fined over $7 million by the FTC. There's been a lot of concerns about how they've managed people's information. There's been a lot of situations where patients have been over-medicated, like getting medication from 2 different providers, and even the therapists themselves complaining about being overworked and having high demands put on them. And I think the way I look at this, I think in healthcare, it's difficult when you have, the folks that should be focused on is obviously the patient, the clinicians from, I don't care if you're MA, nurse, doctor, nurse practitioner, whatever. But when you're focused first on stockholders, because the third group that I mentioned, they are now public. They've gone public. And so their first priority is going to be making sure their stockholders are happy, that they have a certain type of growth. And I think that creates a nasty, slippery slope between mission and, staying in business, and where growth is required. There has to be certain, you have these quarterly updates that you have to provide to your stockholders and stuff like that. And I think, although that might come off as naive from my perspective, I think is terrible for mental health, because we need folks to know that the majority of actors are fantastic. Like you said, they get into it for the right reasons. They're very passionate. But I hate the idea of there being folks coming in here thinking, like, all of a sudden smelling a dollar. Like, as soon as funding actually starts coming in, that they're going to be like, ooh, how can I exploit these folks and make money off of this? And I want people to be aware of that there are some bad actors, to make sure that they're doing their due diligence, looking up reviews or Googling the company to make sure that they haven't had action taken against them.
From when I first started getting a sense that, business venture capital was coming into this space, I just didn't understand it. Like, how do you, this isn't a field where people are making money.
Right.
I mean,
Right.
so I've never made a connection, with why they see mental health as a field to squeeze a profit out of.
Right.
And,
I mean,
there's that conflict of, there's a conflict of interest, right, between shareholders and what you have to do for the patient. I mean, we've seen this in this state.
Yep.
Big blow up last year, right, with
Yep.
with one of the systems, and tremendous blow up. So I don't know. It doesn't completely make sense to me, but I know that I listen to sports radio in the car, and when I hear that one of those vendors you mentioned is constantly advertising on sports radio,
right.
It's not a natural audience that's I think that's gonna be inclined to pursue mental health. I don't know. It strikes me as a strange fit.
I think from the business perspective, you look at the highest in demand specialties, and I believe right now it's dermatology and mental health, because you have big wait times for mental health.
Yeah.
So if you have folks in mental health who aren't taking insurance and are just charging hourly rates, you can get some pretty good returns on that. Now, I don't think that's what these folks are doing, but I think it's just kind of, it's like sharks smelling blood in the water. Like, they're trying to figure out what it's going to take to turn it around, which is a disgusting way to paint, especially your industry. But I think that's what it is. Like, because that's what's going to happen. As soon as, if all of a sudden my wish came true and there was really strong funding going in, especially to Medicaid, that there's going to be that element, which is why, as much as I hate regulations, the regulatory process is there to prevent bad actors from doing such things, so that there are clear penalties when there's a violation of something that goes against what's in the best interest of the patient.
Yeah. It's making me think, obviously, physician owner of an independent practice needs to worry about the bottom line, and I think a lot of the concern that we heard about when practices were starting this, as I've been working with practices now, they worry about, are we going to lose money doing this?
Right.
And ensuring that we're at least breaking even. It was important. That was our,
I've been the same way with my practices. Like, I wouldn't, like, some people told me, actually one individual that I used to work with, but I'm not going to bring him up right now, but it's just like, Tim, you can't tell them that this is typically a money loser. And I'm like, well, it often is, but and this is back in right around, God, I think probably right around 2019 or something. I was doing some education stuff with the PPOC, actually. And I was like, but I don't lie about things. I'm going to say it as it is. But I said, if they follow the what I can see as like a rev cycle guy, I can see how you can maximize it, and you can make a profit. It's extremely difficult. A reasonable expectation is if you do things responsibly, have staffing responsibly, can manage everything the way you should, and get the returns that you should. Breaking even, I think, is a realistic look, and if you're lucky, you might be able to make a dollar or two. But folks that are just gonna haphazardly try to throw this in here and thinking they're gonna, like, I don't want them thinking they're gonna make a fortune. They're gonna be upset about that, because again, this goes back to where the funding is at for how much people get reimbursed for these services. It's not, and so there has to be a realistic expectation for that.
Yeah, and so managing that risk of, you know, starting something new, and am I going to be losing money doing this? You know, because that's the, you know, that's the sense that people have about mental health, and you know, again, this gets back to this idea of it's not just a clinical matter; it's an operational matter too, right?
No question. Yeah.
Because if you're attending to this, you know, in a business way too, you're not going to, you know, be losing money. You know, you're not going to be getting rich doing this.
Right.
You may make a little bit of money that you might be able to reinvest in your program and grow it and build it, and, you know, hire more staff. But, you know, and in fact, you know, there was one team that we worked with, and you know, they were an outlier. They said, you know, we don't even care if we bill for these services, because this adds so much value to us as physicians, to the families we care for. We just want to provide this service. And in fact, you know, the managing partner said this to me. I believe that every one of our physicians, you know, it frees them up to, you know, if they can see a couple more patients a day because they're not getting dragged into these mental health things. I have 25 physicians in my practice. That's going to cover the cost of this. If each of them can do 2 more visits a day, you know, so it depends on how you count the beans.
I mean, I'll tell you this, right? I would never have my kids going to any pediatric office that does not offer, that does not have either a very clear bridge or some form of mental health services that they provide on site. I wouldn't take my kids to a practice like that. So I think it can be something that you can advertise, that can grow a practice, especially a new emerging practice. You're starting up a pediatric practice. I think it's a must at this point.
Yeah. And again, that was, you know, we placed this emphasis on, you know, the operational, the business side of it as just as important as the clinical side. Obviously, we're aiming for these clinical outcomes and want to provide that care.
Right.
But we have to do this in a way that, you know, is at least break even, you know, we can't be losing money doing this. And we were lucky, you know, we had, you know, we provided a lot of support to practices around the management, the billing, the contracting. We had a tremendous person, you know, Leah, right?
Oh, yeah.
I mean, she was one of the most important people in sort of quelling those concerns. You know, she gave the business side people such confidence. Yeah, you can do this.
I mean, I've done some things with Leah, and I just don't know, like, she was put into, when she came in, I think she came in after, who was her predecessor? What was it? Hennessy. Who was a very dynamic person as well in the industry, and glad to still have her in the industry. And when Leah came in, I was just thinking, like, how long can this, when I first met her, I didn't know her well. And I was like, how long can someone last? This is a very difficult position to be put into. Like, most people, I think, would fold after 6 or 12 months. And, you know, sometimes I would send something out to Leah, and she'd be like, I don't know when I'm going to get to this, Tim. It might be months from now, because I can't even imagine how to, you know, and my stuff was not high priority stuff. It wasn't like actual healthcare things that were affecting anybody. But she's always been like, I don't know how, she's always been pleasant to deal with, and is still in that position, right? I think she's still running things. I think she might be watching too. I know that she had enrolled in the RSVP thing for this. So
but what she did was so important in giving the practice that sense of, like, okay, we're not going to go under doing this, you know? And, you know, we used to say that, you know, billing for mental health, it's not difficult. It's just different. If you can do medical billing, you can do behavioral health billing.
I think behavioral health is easy.
There were about 95% of the billing was made up of about 7 procedure codes.
Right. Well, and most practices are doing like 3 or 4 of them. You know, most practices weren't doing group and things like that.
The most unfamiliar thing was this idea of a carve out, you know, and having to submit the bill to somewhere else in the, you know, the medical insurance.
I mean, behavioral health insurances with like Beacon, which is, I know they're not Beacon anymore, but that part, I think, a lot of people had struggles with credentialing with new insurance companies if they were like a long established practice.
But that was, just the idea. Well, the bill goes to a different place than the insurer.
Right.
Yeah, because it's a carve out, and
Yeah.
and once they got some experience with that, they're like, oh,
Yeah.
it's not difficult. It's just different.
Right, which is exactly what you're doing with all the other aspects of the practice. So like the credentialing folks had to understand, okay, these are some new payers you might have to deal with, and this is how you're going to have to enroll with them and what their timing is or whatnot versus, what you're instructing for the medical clinicians to watch out for or how to handle certain cases. I think, like you said, it's a top to bottom thing, and everybody plays a role in that, and everyone has to make some changes. But also, if you give a damn about what you're doing, you're willing to make those changes, because that's what moves us from the pre-COVID state to the post-COVID state where we are now, where now you have, instead of, what we had before that, now there's these expectations that people have for the care that they're going to get, which is much higher, which is, I think, was woefully needed in the pediatric. You can do the same thing on the adult side. I typically gravitate towards PD. I like kids a lot more than adults. They're far more interesting. No offense to all of our audience who are all adults, I'm sure, but they just are. They come out with things. Oh God, I can't get enough. But okay, so wow, that's a lot of stuff we just tackled there.
Yeah.
That is quite a bit. Okay, so now let's give you a little bit of a plug here, but also talk about what you're up to now. So we talked about how you're still providing psychotherapy services. Do you have a certain focus? Is it general, or are there certain cases of folks that you typically try to focus on?
I think my practice, I think about now, it's largely focused on adolescents, young adults, although I care for people across the lifespan. I don't do therapy anymore with like really young kids. I used to, but getting on the floor and playing isn't as very, I'm not built for that anymore.
Yeah. Oh, I love that. Well, you see, like there are some practices that are they bring dogs into the practices.
Yeah.
You have, I have a client that does dance therapy. There's, folks that, of course, engage with art. There's a group in Stoughton right now that are doing Dungeons and Dragons to help people with understanding perspectives of other people. So they have the kids playing Dungeons and Dragons to understand, like to help with role playing, and they can play characters that are just like themselves.
Yeah.
They can play a character that might be like their father, yikes, or their mother, even scarier. But it's, the diversity that we're seeing now and finding different ways to come at it with I think it's really interesting. I love seeing this, because you're going to find new ways, and it can be customized on what actually sticks with what kid. Just because you do it this way doesn't mean that's appropriate for this kid. They might need something different. It doesn't mean one practice is better or worse. It's just what's right for the child, because again, the diversity amongst children is impossible to computate. It's massive.
Yeah.
So all right, so you're doing that, and you're also doing consulting work for what, like other organizations that are, do you still help out like pediatric practices to integrate behavioral health and stuff like that?
Yeah. So when I left Children's Hospital and started my own thing, one was growing my psychotherapy practice, which I had continued to do, but on a small scale. And then I started Crossroads Health Consulting, which is helping practices and other organizations sort of, do integrated care in a variety of ways. So one example is I'm doing some work with the Massachusetts Child Psychiatry Access Project.
Yes.
So last fall, we launched a learning community to help pediatricians, learn the sorts of things, that help them identify and care for patients with behavioral health concerns. So we've been doing that. I've been working with some individual practices to help them, operationalize and integrate primary care. So I'm trying to keep a hand in it in that way.
Yeah. It's like Massachusetts has so many programs now, also falling under the mental health banner. Like my oldest child, she's going to be they're going to be a sophomore this year. But I guess there's a program in Massachusetts right now that has, for juniors and seniors, that they can have for folks that have autism, they have these programs now where they can earn college credits prior to leaving. And I think it's focused on certain type of mental health issues that certain people have. And it's hard to even find, even for me being in the industry, there's so many different resources and options now to go with, and programs that are out there for literally whatever it is that you're dealing with. Some of them are federal, but there's so many just in Massachusetts that are state-run programs that are extremely helpful for whatever it is that parents are dealing with at home.
You know what you were saying? My mind took me back to something you said before about, families having to wait to get behavioral health care.
Yeah.
And one of the things that is so exciting when you integrate it in primary care, a physician can say to the family or patient, listen, I'd like you to meet somebody on my team that can go a little further, talk to you a little bit more about this. And you can meet them right away today while you're here. They're like, what do you mean? I can see somebody right now?
Right now.
I don't have to go somewhere else and get on a wait list. And
well, it's like, I know in grade school, and so my youngest is in Easton in grade school. She's in 4th grade going into 5th grade. And they do these placement things. Like they know their kids really well. So they can say, oh, your child is going to be better with this teacher. So they have a conversation with the other teacher. This is what this child's like. I think they're going to work better with you. So similarly, you have your pediatrician might know you pretty well. I mean, granted, they do have a lot of patients, but they've seen you over the years. They will retain some of that. They have your whole history there. They can get refreshed on that. And so they likewise too, depending on the size of your practice. But if you have a really large practice that has several psychotherapists, they can figure out who might be more appropriate, even if they're not in the practice, even if they're a part of another practice, but be able to better place. And I think that's, again, why, pediatricians, it's not like, I think with some specialties, it's, doesn't have to be that focused. It has to be someone who's really good at being able to perform such and such procedure. But I believe in mental health care, it's very different, where you have to have a placement where that child is going to connect with who it is that they're having therapy with, or managing their meds as well. But more importantly, I think with the counseling aspect of things. So having somebody that can try to help you navigate that has to be infinitely powerful and have better outcome as well.
Yeah. Yeah. Well, it made me think of a really great example of integrated care. Clinician, one of the things we train the behavioral health clinicians to do, and ideally, they do this with the physicians also, whether it's a day ahead or a few days ahead, you're sort of scanning the schedule. You look in the schedule, see who's coming in, look at their screening, look at their history. Do they have a diagnosis? So you can kind of get a sense of what my day might be like, who might be good to see.
Right.
So one of the clinicians was scanning the schedule and noticed there was a father a parent was going to be bringing 2 kids in. The 2 kids and the mother had been involved in a motor vehicle accident like a couple weeks before. Nobody was seriously injured, but it was a traumatic experience. Yeah. And the clinician had noticed this, noted in the record. And so there was a bit of a wait, and went to the physician and said, hey, can I check in with this father before you go in the room? Just, it's like, yeah, go ahead. I'm going to be delayed a little bit. Yeah. So the clinician goes in and, acquaints herself with the father and says, what about this motor vehicle accident? How, is everybody okay? And he goes, oh my gosh, I'm so glad you asked me. Nobody was injured. The kids seem fine, but we've been really worried. Like, is it,
wow,
about the impact of this.
Yeah.
And
yeah.
in a one-shot deal, she was able to educate the father, give him some guidance on what to look for. And, and a couple weeks later, he came back, things are okay.
Oh, that's hot. Yeah.
And it was just a great example of, anticipating what the issue might be, right, getting in there and asking about it and say, I'm so relieved you asked me about that. I've been worried about this. And then, a couple of hours, she was able to sort of equip the father, reassure the father, equip him with some, developmental guidance about what to look out for and how to manage that. It's a beautiful example of what that is.
And so I'll say, parents like me, I'm largely oblivious to that type of stuff. So like, if I was in a car accident, I would check in with my kids, make sure everything's good or whatever. And if they seem fine, it would be out of my head.
Right.
So having someone come over and say, oh, is everything okay with your kids? I'd probably be like, yeah, it's fine. I mean, you can talk to them if you want or whatever. And then they talk to the kids. They'll be like, no, I was so upset. Like, what happens if something happened to my dad or my sister or something like that?
Yeah.
And I'd probably be blown away. Like, oh my God, I didn't realize there's a need here. Yeah. Because everybody reacts to things differently. And just being smart enough to have that check-in. Oh my God, that's awesome. That's a great story. And that's what we really want to be happening across the board for things like that.
Yeah, and then one of the things we encouraged practices to do was to pick a population where you would expect, some issues to be coming up, like the transition to high school.
Yeah,
So that's tough for a lot of kids.
absolutely.
So focus on that. Like let's really look at the kids that are going to be coming into high school next year. Let's pay a little bit more attention to this group when they come in and dive a little deeper, figure out which kids are really anxious and worried and may have some trouble, and get ahead of it.
Right.
Yeah,
I totally agree. And then because you have some kids who are already diagnosed, like let's say, for instance, you're diagnosed with social anxiety at 8 and you get therapy for a couple of years and you understand how to see it coming, different tools to use or whatever. And by 10 years old, you're feeling pretty much like the master of your house and you no longer need that therapy. Cool. Let's end these counseling sessions. Let's move on. Good. We've equipped you with kind of like training wheels on a bike. Now you can ride. But now you enter high school. Social anxiety is a different beast.
Yeah.
Even in middle school, all of a sudden now you have puberty hitting. You have all these other things that are going to factor in, and you haven't been trained. Now you have to go back into counseling to better understand that. So I think even for folks who have managed, especially if they have previously been diagnosed.
Well, and you're talking about the kids where there's an issue.
Right.
But if you have this cohort of kids transitioning to high school, most of them are fine. But if you focus on them asking these questions, you're going to detect more cases like, I'm really worried about, the social part of high school, or, how hard it's going to be. It's the kids that where it's lurking just beneath the surface of sort of clinical significance, if you will, where you get a lot of bang for your buck if you, again, address it early before it becomes a problem. Don't allow it to travel downstream and get bigger.
Yeah.
Address it as far upstream as you can.
Yeah, and I like that term you just slipped into, clinical significance, because I also look at, or I shouldn't say also, because I don't know if you agree with this or not, and you're going to know when I don't, but I see a lot of mental health disorders as items that everybody actually has, like social anxiety, right? I would say I don't have social anxiety. I'm extremely extroverted. I get all my energy from meeting people. I think I'm far to that extreme. You put me on New Year's Eve in the middle of Boston, squished in with thousands of people, I will freak the hell out, right? So does everybody just have social anxiety, but they have different thresholds? Whereas, in my situation, it's not going to be diagnosed as a disorder because it doesn't really interrupt my day-to-day life. But if I woke up in the morning in my bed and I take a breath and all of a sudden I'm feeling anxious and there's no actual reason for, like an irrational feeling, now this, I guess, would be a disorder. And I would say the same thing with OCD. I wouldn't consider myself somebody that suffers from OCD, but there's certain things I definitely want to be done in certain ways. So are a lot of these things, these disorders, just mental health aspects that generally most or everybody has, but it's only when it gets to a point that it's disturbing your day-to-day life that we need to treat it and call it a disorder? Like, do we all maybe even have autism? Do we all have like a lot of these items that just are either not interfering with our life as much as others? This is more of a spectrum.
No, I think you're right on target. I think there's a continuum sort of being, and, this is what we used to teach the clinicians, it's frequency, duration, and intensity, right?
Okay.
Like I get social anxiety times going into a new situation.
Yeah.
Anybody does. These are so
Walking
normal,
on a show with
right?
a professional like me must be terrifying.
I was terrified. But it's how much it impedes, your day-to-day functioning.
Right.
And most of us have these we call them quirky little things that we do.
Sure.
Could you diagnose it? Yeah, it looks like sort of a diagnosis, but it doesn't get in the way of my daily life. It doesn't happen as frequently, or the duration doesn't last as long. Right. It's not as intensive as if I met criteria for a diagnosis.
Yeah.
We all have those variabilities in the way we are that,
right.
Oh,
that's so interesting. Yeah, these are just kind of thoughts I've had over time, and it's interesting that they're actually valid. That's because you never know. I mean, you've studied this your whole life. I'm just some jabroni that thinks over the weekend about things like this, or I just see what happens with my kids, and then I'm just like, well, I can kind of, situate, because I try to understand it. So when my oldest first got social anxiety, I just couldn't understand it because I so infrequently suffer from it. But the more they talk to me about it, then eventually all of a sudden I could kind of get it enough to be able to help them out.
Yeah,
and I think from a parent, that's That's like a big thing, is like, as soon as I know one of my kids, I don't care if they all of a sudden get into soccer. Now I care about soccer. They don't want to do it anymore. I don't give a damn about soccer.
Yeah.
And so for something much more impactful like this, having these diagnoses, whether it's a health condition or any healthcare condition, but something that affects the mind, is so less obvious. You can't,
Yeah.
if my kid has a cut on their shoulder, I know they have a damn cut on their shoulder. I can see the blood.
Right.
But a lot of these things we're not trained in as just being parents. And so when we're trying to understand certain characteristics of something, or even know when it's an opportunity for them to be seen and diagnosed or evaluated even, it's often too late, or it's often well after it started. When my oldest was getting diagnosed, I was kicking myself, because there would be times where they would come home and just go right to bed. And I'd be like, "You're lazy. Come on, get up. Let's go. We have these things to do." But they were going through autism burnout. And I had never heard of that before, nor did I even know they were autistic at the time. But but as soon as I knew, I'm diving in, I'm trying to learn. I'm like, oh, I was a real jerk at this time, which isn't fair, I get.
Yeah.
But like, it's just, I think it's just a difficulty from the parent perspective. There's so many things you're juggling. And then and then you just realize that they must be suffering so much worse, because they also don't know it. So they also think they're being lazy.
Yeah. It's making me think again about screening, and sort of, through the portal, kids would be able to complete the screening, and then, the information would be available. Unfortunately, in the EHR, if the screening didn't indicate anything, the indication would be green, like green, go. And if there was some indication, it would be red.
Right.
Unfortunately, you want to, even those kids where there's negative, finding, you want to inquire. Like, if you are seeing a kid who's a junior in high school, they're not reporting any anxiety or stress.
Right.
Like, go ask about that.
Right.
Wow. Most juniors I know are really stressed out. You're not. What are you doing? How are you? Okay, do more of that then.
Right.
Reinforce the healthy behavior.
Yeah.
Right? It's a great opportunity. You don't have to have a diagnosis or even be symptomatic.
Sure. Yeah.
The kid's fine.
Yeah.
Well, what's keeping you fine? You're at a stage where everybody's stressed and anxious, but you're not. What are you doing?
Yeah.
I'm doing this and this. Well, do more of that.
Yeah. Interesting. Yeah.
So don't ignore the negative finding. I mean, it's an opening, a window to have a different kind of conversation with that patient that's sitting in front of you.
And like the ironic part of it is that once you actually get a clear understanding of what's actually going on, it actually settles you down.
Yeah.
It's not like, oh, why am I so weird? It's, oh, I'm not weird. I'm not special. There's 5% of the population like me. Every 20th person is going through what I'm going through. Then all of a sudden it gets this feeling of camaraderie, which is one of the things I like about group, which should not be limited to psychotherapy. I don't care. Like, I grew up with terrible asthma, and I feel like you have other people in a room. My clinician doesn't have asthma. My parents don't know what it's, because when I was growing up, it was asthma attacks where you're gasping, like you're convinced you're about to die. You can't breathe. It's managed completely differently nowadays.
Yeah.
So differently. But if I could have talked to other people around that time about these type of things, like, oh, how, what do you do in these situations? Oh, and you meet someone that has it worse off than you with the same diagnosis, or someone that's better. Or maybe you can help this person because, oh, in those situations I do this. Oh, I never thought of that. And you get validation. I think group for anything is helpful. If you have like a rare form of cancer, if you have whatever it is, it's great, I think, when you can pair other people up. There's also, just again, I gotta always go through the rev cycle side because that's in my head. There's not really great it often is not reimbursed unless there's like in psych, there's a lot of reimbursement for group. I mean, as long as you have you have to have at least 7 people, I think, for it to really turn into something that is a profitable model. I don't even know why I'm saying it like that, but that's just how I'm wired. But in med, it's a lot harder to make to talk to folks about how it's useful. And that's why so many people go into like Facebook groups to find like-minded people or people in a similar situation.
Yeah. Groups was a big thing we were trying to push as part of the model. And it's hard. I mean, groups are logistically, pragmatically a little bit harder to kind of start, but the types of groups, that we could do. Also, a lot of them, the ones we were pushing, sort of fit that model of sort of wellness and prevention. Like, again, I'll pick on the kids that are starting high school. You probably got a lot of anxious parents too.
Right.
when their kids are
Yeah,
starting high
of
school,
course, yeah.
right? So if you do an educational group or a workshop for parents
Yeah.
of, kids entering high school,
Mhm.
you get that feeling of, camaraderie, of, learning from others' experience.
Right.
And you're doing something that helps equip those parents, to be more vigilant about what to look for, what not to
Right.
worry about.
Right.
This is normal, kind of.
Right. Yeah. I think anyone
Yeah.
who remembers their high school should be terrified when their kids go to high school. And I'd
Yeah.
also add in that I think that in the age of telehealth, I think there's, perhaps another new opportunity. You set a group up for 6 p.m. in the evening on a weeknight or something like that. Generally speaking, those kids are probably going to be home and could potentially jump onto something like that. Like the
Yeah.
logistics of getting people to go to a practice physically is, almost impossible.
Well, it, again, it's the location too. I mean, it's the drive time. I mean, for
Yeah.
some, parents, that involves taking time off work, maybe
Yeah.
losing money, gas, parking. It becomes a big deal for many families. And if you can go home and get on the computer and you save commute time, you save,
Yeah.
it's so convenient.
Right. Right.
I'm a little bit concerned. I see now in the world, especially, people in my profession, generation or 2 generations younger than me, who are only, their experience is only providing that kind of care.
Right.
I worry about it a little. I mean, it's, worries of a dinosaur, but um, uh, it's so convenient. Families embraced it so quickly.
Yeah.
While my clinical practice, I mostly see people in person, but sometimes a kid is sick, and I can flip it to a telehealth visit rather than a cancellation. Helps the kid, even though they're home
True,
sick.
but I don't think. Yeah. I'm sorry. Go ahead.
Yeah, or I have families that have to, something comes up, the parent can't bring them.
Right.
Okay, I can switch it to a telehealth visit
Right.
quickly.
You have a mobility issue, or especially people who have like disabilities like they're hard of hearing or
Yeah.
sight and stuff like that. I think, but I don't think your what you brought up there is necessarily like a dinosaur thing. It might sound like it. I get where you're going with that, but I think that, we always see these pendulum swings, and we've been so starved for telehealth that we're seeing it now swing. And like most times, it usually will swing too much. So you see, like, I can tell you this, even at my office, there are people who are petrified at the thought of calling up a place to make a delivery order for lunch, where they're so used to now going, you have the online ordering, it's easier, or it's less interactive and things like that. So I wouldn't be surprised if you see, I mean, how many mental health conditions have come out of people having smartphones now? And so, and I mean, I'm probably ground zero for that. Like I was talking to you about my use of AI now, and you're going to forget how to do things, or you're going to be so reliant on some technology. Like I used to have all the handout maps, like the big maps, and I would know every town, and I would love that. I was like so obsessed with that. And then MapQuest came out, and I was just like, whatever, I know my stuff. I'm not. And then GPS came out, and now I don't know how to get damn near anywhere. How would I have gotten here? I'm not pulling out a map, right? So we're already used to systems that think for us, and then it atrophies the brain, and now we don't know how to get anywhere without our app. And I think AI is going to be very similar to that, or already is. So there's going to be outcomes from telehealth that could even create new diags. But I think that telehealth, without question, is a necessary part of healthcare. We need to have it, but it doesn't mean that there aren't going to be situations where someone now abuses it or creates new limitations in their lives that also will have to be addressed.
Well, there's a slew of, apps and websites now that help people. And, are those resources that are going to, be the most important thing to help people? Maybe not, but they're wonderful adjuncts to care.
Yeah.
Yeah. Combining that with, traditional care and then sending somebody home, go check out this website or use this app, in between, today and when we meet next,
Right.
And, earlier in my career, I was involved in that world of interactive health and creating those sorts of tools. So I really value those maybe in a way that some people don't, but they're wonderful adjuncts to care.
Yeah.
And there's some really great ones out there. The problem is a lot of them are not developed by experts. They haven't been subject to, clinical testing. They're, the outcomes are not, can they deliver the same sort of outcomes or even good outcomes?
Right.
So, we're getting better at that. Some of these are proven in that kind of way.
Which is more reason for people to have a closer tie-in with their clinicians, so
Yeah.
they can ask them about that. Like in the same way I had somewhere like in the middle of this where, oh crap, we're already over our time, but where, I was talking about bad actors in the group. Like, not only do I think clinicians have some kind of responsibility to try to help people with that, but even with it, like, I like that idea of being, having assists through different type of apps, but you could also help navigate folks. If they say, oh, I'm using these apps, you could say, okay, well, hold on, let me do some research, and I'm going to find out, like, you probably, like, this is just made by somebody who has absolutely no credentials. Like, this is coming out of, somewhere that I can't even trace where this came from.
Right.
This might not be helpful. I can tell you, here's what's certified by organizations that I know are very responsible and are great actors and here's a list of 5 for you to choose from or something. I mean, I think that's where the relationship needs to be. It needs to be something where it's just helpful. And I like that attitude too about, it's not all just about me as your counselor. It's also going to be other folks that can help you out.
Yeah. Yeah.
It's interesting. Okay. So since we are over, and I think there was some issue here because I can't access comments, unfortunately. So if there are people here who are commenting, I apologize for that not coming through. I think there's some screw up here. But let's leave with whatever it is that you want to leave this off on. I mean, as far as we did talk about a little bit of how far we've come. I don't know if you know what's next. I would imagine if anyone does, it's you, because of your great anticipatory process in the late 20-teens. Not that you knew COVID was coming, but the fact that you were working on something in a very proactive way. What do you see coming up as the next generation big outcomes or things that you might be looking forward to in the industry?
I hope this trend of integrated care continues to grow.
Mm-hmm.
I mean, it's in a lot of places now. It's not everywhere. We're really lucky here in Massachusetts. We have a lot of things that's, statewide, state level sorts of things that support that. Within our Medicaid program, practices that have adopted integrated care can get on a higher tier for reimbursement, things like that. There's a lot of incentives. But I hope it keeps on growing, because it destigmatizes, mental health concerns,
Right.
It normalizes it, reintegrates the mind and the body. I said to you earlier when we were talking before the show, at the beginning, it was really exciting to be implementing this and seeing families get access to care.
Right.
That was really great.
Right.
Easy access.
And you worked with like cancer patients, you said before too,
Yeah.
which is also because it's not just PCP, also certain specialties would
Yeah.
demand that type of help as well.
Yeah. But what became more exciting was the impact this was having on the pediatricians, the clinicians, the medical clinicians.
Oh.
They were saying things like, I feel more capable and comfortable addressing these things than I ever did before. Thank you.
Wow.
And I would think,
I never even thought of that perspective.
this person touches hundreds or thousands of lives.
Right.
So if I can empower that person and help them do a better job, that's exciting.
Wow.
I mean, the fact that families are getting better care is exciting, but empowering these clinicians who are now able to address something that they felt like was out of their purview.
Yeah.
I can do this now.
Right.
I mean, I had a pediatrician say to me that the integration of behavioral health and primary care was the most important thing that happened in pediatrics since the invention of the vaccine. I thought, wow, there's a lot of things that have happened in pediatrics since then.
Right.
And he said, no, this is important because it empowers me. It makes
so
me feel
important.
confident
Yeah.
doing something that I felt really not capable
Yeah.
of doing well before.
Yeah.
And that's exciting.
I can.
And that's why I hope that this continues to grow. I want physicians to feel like, I'm not becoming a psychiatrist. I'm becoming a better physician because I can start the process, hand off to a specialist on my team that can then take the baton and run with it.
Right. Oh man. Yeah. I mean, so and a lot of I was going to close it out there, but I swear to God, I
Better be careful. We could talk for hours.
I know, right? This is, if we go 3 hours, then we've turned into Joe Rogan at that point. I guess the other thing I wanted to say was, I know there are folks in your industry who have certain type of specializations as well. There's subsets and specializations. I know most folks are very general and can manage a whole slew of issues and stuff like that. What do you, if somebody was, let's say, for instance, somebody, whether you've been living for 40 years with, let's say, survivor's guilt, for instance, or whatever the situation is, and you think, oh, it's too late or whatever. And I'm sure, obviously, it's never too late. As long as you're still alive, you can help. It'll help out with your relationships in life and all this other stuff. is there a really good central resource for people who, regardless of what it is that they're suffering from, can utilize to figure out where they should seek help? You know what I mean? Like if someone was like, is there a general like psychiatry site or that where they direct folks to where you can find good psychologists or social workers that can assist them based on need? Or is it really kind of like you should go to maybe bigger groups and just kind of see what they specialize in? Like, is there a really good comprehensive way for folks to seek care for a specific piece of mental health that they want to find someone that specializes in it?
Yeah, there are. I mean,
Okay.
I can't think of exactly what to say to direct people to, but what it's making me think about, this was one of the challenges in hiring clinicians for primary care.
Mm-hmm.
I mean, a primary care, physician is deals with a lot of stuff. They're a generalist, right? Anything that walks through the door.
Sure.
And because mental health people tend to specialize in a very narrow band, they're not like anything that walks through the door. I do this or I do this. That made it a challenge to hire the right kind of clinicians for primary care. I don't want to just work in this band. I want to work here. Right. So finding a clinician that, because anything that walks through the door, I can handle that. At least as a starting point. I don't have to be the specialist that, and in the same way that if you're a physician and you're the one that discovers a patient of yours has cancer, you're not going to treat them for cancer in primary care.
Right.
You're going to send them to a specialist.
Yep.
And the same thing with behavioral health. It's the first thing. You're going to try to intervene in primary care because that's the first place. Yep. You're going to try a primary care-based intervention as best you can. Mm-hmm. If you're not getting the results you need, then you're going to have to refer them to a specialist. Right? Integrated behavioral health you're not going to treat everything. Right. It's a starting point for everything, but as soon as you realize this is not a primary care level problem, it needs something more. Right. But you've started, and you've started in a place where the family has a relationship, they trust you, and they may be more willing than if you started with them to then go on to that specialty level of care.
Yeah, and I think also, like you were saying before, most folks in the industry are so passionate about what they're doing. They're going to be matching people up with, if it's something like, okay, you have a teenager here, they have a lot of, such and such items going on, and they're teenagers. Oh, they really like basketball. They should have therapy with someone that can like they haven't opened up to anyone in 3 years or something. You know what? I know this person. He'll go out and he'll shoot basketballs with, they'll go play together until all of a sudden they think they're just having a conversation and they'll open up. Yeah. That's not what I'm really good at, but I'm going to refer you to this person. I think most folks in your industry are very much like that, like very, very helpful in that process. If it's not a good match, they're going to pass them along, and it's just going to try to take every patient they can get.
Yeah.
Right. Yeah. Because I actually give a damn about the outcome. Awesome. Well, all right. I mean, I think the best thing is that I really have to go to the bathroom, so that creates an actual way to call an end to this. But I was very, very much looking forward. I really appreciate you making the time. And I also want to, and I'm sure I'll say this on behalf of so many other families, I want to thank you for the work that you've done and the team that worked with you, even though I don't really know who they all are. I think I know a few of the folks, but I know most people don't know any of you guys. And you guys did a lot of great stuff that have helped out so many parents, so many children. And I think it's going to be something that's just going to continue to pay dividends long after you're gone. There's going to be other clinicians that are going to be building off of what you started here. You've done some amazing stuff. So I just want to thank you for that.
Thanks, Tim. Pleasure to talk with you. I could talk on and on about this. Yeah. I love it. I'm passionate about it. I love when we first met, you were very interested in what we were doing.
Yeah.
I know you followed it over time. It's great to be able to touch base with you at different points of it. And
I feel like often with folks like us, we loosely stay in touch and maybe actually see each other once every several years. But it's great when we actually do that. So who knows? Maybe I'll come up with, maybe if I run dry on guests, we'll do a part 2 or something. But anyway, for the folks that are watching, thank you very much. We'll see you at the next one next week. Who do we have? We have Walter Sussman. So I'm going into the medical side. He's got this practice in Waltham that is this amazing frontier of sports med, orthopedic work. He's doing some stuff that really no one in the country is doing. And so we're going to get in a little bit more on the medical side and talk about things that you probably don't even realize, certain type of services that are actually out there. So we will see you at the next one, guys. Thank you very much.